Well, thank you very much for joining this talk. This talk will cover fetal echocardiography and will really be a primer of fetal echo. So just kind of hitting the high points of what fetal echo is all about and how it can help us manage fetuses with congenital heart disease. So when we think about the goals of fetal echocardiography, there are really three goals. One is in counseling the family as far as their fetus and their fetus's heart condition and what to anticipate both during the pregnancy and after delivery. The second is to plan peripartum care, and that includes the serial follow-up that may be needed during the pregnancy, the care that will be needed at the time of delivery, and then the care that will be needed as we move on past delivery and into either medical or surgical management. Then the third goal is that of prenatal therapy, and that area has really grown immensely over the past decade or more to include fetal interventions. And we're not going to discuss those as much during this talk because that's a talk in and of itself, but certainly prenatal therapy for other issues with the fetus, particularly rhythm abnormalities, we'll be spending the majority of our time discussing that. So when we think about counseling, there are prenatal issues that we need to counsel the family about, and that includes what is the congenital heart lesion that the fetus has, what's the overall clinical severity of that lesion, and what's our predicted outcome, both during fetal life and postnatally as we care for that infant after delivery. It will entail serial fetal echo assessments in many of our fetuses with congenital heart disease because the overall severity of the lesion may indeed change during the gestation, later gestation of the pregnancy. There are neonatal issues that we need to counsel about, including both the need for medical management after delivery, or is that fetus after they're born going to need surgical intervention in the first few days of life. And then important issues to discuss with the family also include genetic issues because congenital heart disease is a genetic issue. About 1% of pregnancies in the United States have a congenital heart lesion associated with them. And with that comes a recurrence risk that's very important to families as they plan for any future additions to their family. Peripartum care is very important to fetal echocardiography in that it helps us determine the site of delivery for the fetus. Does it need to be a tertiary care medical center or did they deliver closer to home? It also helps us coordinate the medical team that's going to be managing the neonate after delivery, including our maternal fetal medicine colleagues, our neonatologists, pediatric cardiologists, and our pediatric cardiothoracic surgery team. And with this coordination of peripartum care, is actual outcome of fetuses improved? Well, there have been several studies that have looked at this and have reported varying results. But for the most part, those fetuses with critical or significant congenital heart disease, they do benefit from having a prenatal diagnosis and by having their perinatal care coordinated, both their medical and surgical intervention post-delivery. You can see in this study in patients with critical aortic stenosis or hypoplastic left heart syndrome, those that had a prenatal diagnosis fared much better than those that had a postnatal diagnosis with regards to acidosis, the incidence of cardiac arrest, overall survival, and length of postoperative stay. Prenatal therapy is also an important component of fetal echocardiography, both from a pharmacologic perspective as well as a interventional perspective. From a pharmacologic perspective, the maternal fetal route or the placental route is a very common way that we use to treat fetal abnormalities, most importantly, fetal arrhythmias, when those need to be medically managed. You can also have direct fetal administration of various drugs via a intramuscular injection into the fetus. And those are particularly done in very sick fetuses that are hydropic and are not absorbing medications through the placental route as much as we would like them to. Surgical or interventional procedures have certainly come into vogue over the past 10 plus years. The interventional fetal cardiac catheterization is well known for fetal aortic valvuloplasty, as well as atrial septostomy in patients with hypoplastic left heart syndrome that have a restricted atrial septum. The era of fetal cardiac surgery is certainly shortly going to be upon us and is being initially performed now in a few centers around the world. So what are the indications for fetal echocardiography? Well, there are fetal indications, familial indications, and maternal indications. Fetal risk factors include the presence of an extracardiac abnormality that's been found on an OB scan. Fetuses that have extracardiac abnormalities have about a 10 to 15% chance of having an associated congenital heart defect and about a 12% chance of having an associated chromosomal abnormality. Fetal rhythm abnormalities, while not that common, certainly occur in our fetuses, and our risk factors including an irregular heart rate, tachycardia with heart rates over 200 beats per minute, or sustained bradycardia. Hydrops fetalis is when you have the accumulation of fluid in two or more body cavities, including a pericardial, pleural, ascites, or skin edema. And about 25% of fetuses with hydrops also have associated congenital heart disease. The biggest reason that fetuses are referred for fetal echocardiography in 2021 is due to a suspected cardiac abnormality on an OB screening scan. And then finally, if there's too much or too little fluid, poly or oligohydramnios, again, this can be associated with congenital heart disease, and these fetuses require evaluation. Familial risk factors to refer for fetal echo include the presence of congenital heart disease, either in the parents or in previous siblings. As I said, about 1% of pregnancies in the United States have a fetus with a congenital heart lesion. If you've had a previous sibling with a congenital heart lesion, your risk of having a subsequent child with a congenital heart defect goes up to about 5%. And if you have two children with congenital heart lesions, then your risk goes up to about 25%. If the parents have congenital heart disease, there's about a 4% increased risk when the father has congenital heart disease, and about an 8% risk of the fetus having a congenital heart defect if the mom has congenital heart disease. There are a variety of syndromes that also have congenital heart disease associated with them that fetal echocardiography is indicated to rule out an associated cardiac abnormality. Just a couple of those would be Noonan syndrome, in which we see hypertrophic cardiomyopathy and atrial septal defects, or tuberous sclerosis, which we see fetal rhabdomyomas, which can be quite prominent related to this syndrome. Maternal risk factors during pregnancy include teratogen exposure, and certainly if moms are taking a variety of different medications, some of those have been shown to have a higher incidence of congenital heart disease. Maternal metabolic disease, and in particular diabetes mellitus, has an impact on the incidence of congenital heart disease, as do other metabolic diseases like phenylketonuria. Maternal infections early in the pregnancy, such as the torch infections or mumps, can also impart congenital heart disease to their fetus. Well, how accurate is fetal echocardiography? And this is an early study from the mid-1990s, looking at the accuracy of fetal echo. And as our technology has improved, as our ability to scan these fetuses at an earlier gestation has improved, our correct diagnoses have improved somewhat, But as you can tell by looking at some of these heart lesions, when you have an AV canal defect, about 95% can be diagnosed by fetal echocardiography, hypoplastic left heart syndrome, Epstein anomaly, all with very high percentage of correct diagnoses. And that's because back in the 1990s, the vast majority of scans by our OB colleagues were merely looking at the four-chamber view of the fetal heart and not looking at other views, including the outflow tracts. Single ventricle anatomy or complex congenital heart disease, a little bit less diagnostic accuracy. And those structures that are influenced by fetal physiology, such as coarctation of the aorta, can be very challenging to identify prenatally because circulatory patterns can be altered in the fetus with obstructive lesions such that flow can be more predominantly through the ductal arch as opposed to the true arch, and can be quite challenging to identify. If you include outflow tracts, if you include other views, you can see from a variety of listing of different lesions here, you can increase your diagnostic yield and accuracy dramatically by adding, and in this study, just adding the aortic outflow tract, but certainly in 2021, with the guidelines that are out, and I'll give you a couple examples of excellent guidelines for you to review, the yield of fetal echocardiography is actually quite high in 2021. Well, what kind of lead to screening failures? How do we miss congenital heart disease on a fetal echo? A lot of these have to do with the imaging windows that we have in the moms that during their pregnancy. So maternal obesity, a fetal lie that the back is up, and it's challenging to get an optimal view of the fetal thorax and the heart. Women that have too much or too little amniotic fluid, such that the fetus is either moving a lot or not moving much at all and is in a poor position. As the fetus gets older during gestation, the bony structures become more filled in, and it becomes more and more of a challenge to image these late gestation fetuses because the windows are quite challenging. Sometimes there are congenital heart lesions where they progress in severity during gestation, and if you image these fetuses at 20 weeks gestation, the significance of the heart lesion may become quite severe later on in the pregnancy. And a great example of this is hypoplastic left heart syndrome, where the left ventricle may look relatively normal in size earlier in the pregnancy, but by the time of delivery, be very small or even challenging to even visualize by echo. And then experience plays a large part in fetal echocardiography. So your sonographers, fellows, attending physicians that are performing these studies need to be very experienced, not only in identifying congenital heart disease, but also in the imaging techniques used in fetal echocardiography. Well, let's talk a little bit about the normal fetal echo exam. The timing for most of our fetal echocardiograms are initially around 18 to 24 weeks gestation. This is the time where you get optimal views of the heart and the skeletal system is not completely calcified yet, limiting your views. Serial exams for congenital heart disease, if needed, will be continued throughout the remainder of the pregnancy. And what, again, we're trying to do with fetal echoes and serial echoes is to optimize the delivery strategy and coordinate maternal and infant management along the course of the pregnancy and at the time of delivery. A fetal echo exam has a lot of components to it that you will find familiar for a pediatric or an adult exam. So we want to have a complete two-dimensional ultrasound of the fetal cardiovascular system. We will look at the cardiac structure and function, the cardiovascular connections, the fetal heart rate and rhythm, as well as assess for extracardiac abnormalities and their impact on the cardiovascular system. Here's a couple of great guidelines that if you're looking for additional information after this lecture to enhance your fetal echo knowledge. These are two great ones to look at. One from the AIUM in the Journal of Ultrasound Medicine back in 2013, and then an AHA scientific statement in Circulation in 2014. Again, there's a lot of information that we're not going to be able to cover in today's lecture, and I think both of these publications give a lot of insight into the value and the various components of having a complete fetal cardiology program with high quality fetal echocardiography. These are just some of the images that are present in that AIUM document, giving you a flavor for some of the image views. The interesting thing with fetuses is we do try to recreate many of the imaging views that we do in our neonates, pediatric and adult patients. However, the position of the fetus is often quite variable and changes throughout the exam. So you have to be very persistent and very careful in how you image the fetal heart as opposed to a patient that's lying still and not moving during the examination. Some of the normal findings that we look for in a fetal echo: the fetal heart should occupy less than a third of the thorax. The cardiac chambers and vessels should be relatively the same size when you compare the left heart to the right heart. So the left atrium and right atrium should be relatively the same size, the RV and LV, and the PA and aorta. In real life, the right-sided heart structures are usually minimally a bit bigger than the left ventricle, but not significantly bigger. You want to focus on the AV valve and the crux of the heart to look at ventricular morphology. Look at the aortic and ductal arches. Remember, there are two arches in the fetus. There's the true aortic arch, and then there's the ductal or PDA, patent ductus arteriosus, that needs to be assessed as well. We can see over here the aortic arch, and here's the ductal arch. Some have described this as the candy cane for the true aortic arch, and a hockey stick for those of you that live like I do in Minnesota or areas where a lot of hockey is played. The ductal arch looks like a hockey stick. And then we want to evaluate fetal ventricular function as well. We do use Doppler with the fetus quite extensively, using pulse wave Doppler to look at atrioventricular valve inflow, both across the tricuspid and mitral valve. We get a signal that's indicative of decreased compliance, which is true in the fetus. Fetal myocardial compliance as well as contractility evolve throughout the pregnancy, and we'll discuss that in a little bit. The umbilical artery and umbilical vein flow profiles are very important for the overall assessment of cardiovascular hemodynamics as well as placental flow. And then we look at color Doppler to exclude any AV valve or semilunar valve regurgitation. With better and better color Doppler in our systems, we do see trivial tricuspid regurgitation in normal fetuses, but the presence of pulmonary, mitral, or aortic regurgitation should be considered as abnormal findings in these fetuses. We also assess the rhythm, looking for a normal fetal heart rhythm, which is defined as 120 to 160 beats per minute. Ectopy can be common, but by far the vast majority of that ectopy are simple premature beats, and we'll talk about those a little bit later in the lecture. We do, as I said, look at the umbilical cord. The umbilical cord has 3 vessels, has 2 arteries and 1 vein, and we use Doppler to assess components of placental flow, so placental vascular resistance, and we also look at flow returning to the fetus from the placenta. So here is the umbilical arterial flow. You see it's a pulsatile flow, and you will not see fall below the baseline in a healthy normal fetus. This is the umbilical vein flow here. Again, very low flow, really not phasic, but low velocity. This is what a normal Doppler venous flow should look like in the umbilical vein. So just a few images to look at the normal fetal exam. We first look at abdominal situs, as we can see over here on the left. This is it. We look initially at the long axis of the fetus. We rotate 90 degrees to give us a short axis through the fetal thorax. And this will be the fetal left side. This will be the fetal right side. And we can look for the base to apex orientation of the heart. In this situation, this would be levocardia. We can also scan, as we see over here on the right, through the abdominal and thoracic cage to look at the abdominal situs, looking for the stomach over here on the left, as well as the liver on the right. This is the typical 4-chamber view of the fetal heart. We can get quite good pictures of the fetal heart. And again, we want to focus on the AV valves, the crux of the heart, the size and function of each of the cardiac chambers. And then we can use color Doppler again to assess for any regurgitation or stenosis, look at pulmonary venous return to the left atrium, or systemic venous flow to the right atrium in the fetus. As I said, the fetal myocardium is relatively non-compliant, and we can see flow across both the tricuspid and the mitral valve having a smaller E wave, a larger A wave, so indicative of early relaxation abnormalities that we would see in our adult colleagues. Our fetal colleagues also have that, but that myocardium, remember, matures throughout the remainder of the pregnancy, and as we get closer to delivery, the EA wave ratio approaches 1, so that we see improvement in compliance of the fetal heart. Here's a parasternal look at the fetal heart, left atrium, left ventricle, and aortic outflow tract with the right ventricle here anteriorly. We can see a short axis view of the left ventricle and right ventricle here in this fetus as well. Moving up towards the base of the heart, we can get nice views of the short axis. Here's the aorta, here's the pulmonary valve, the tricuspid valves over here. By color, we can see nice color flow across the tricuspid valve and pulmonary valve out into the branch pulmonary arteries. When we're in that short axis view, those are the optimal views to look for the aortic and ductal arches. Here we can see a very nice example of a fetal aortic arch. And by color, we can see very nice laminar flow around that aortic arch. This is looking at the fetal ductal arch. Again, here's that more hockey stick sort of orientation of the fetal ductal arch to the descending aorta. You can see that both in the 2D and in the color scan. We not only want to look at the outflow tracts, but we want to make sure that they have the normal orientation to one another, which is a perpendicular relationship. So we should see the aorta and the pulmonary artery crisscross. And here we can see a very nice example of the aorta here. The PA comes across here. And by color, it's much easier seeing. We can see flow in the aorta, flow in the pulmonary artery this way. So there is a normal crisscross of the great vessels that are in a normal relationship to one another. Finally, this is the umbilical cord, 2 umbilical arteries and 1 big umbilical vein we can see here by 2D and by color. And what we want to see is to see our umbilical arterial flow. Again, the arterial flow should not return to the baseline, should be continuous and pulsatile. And then our umbilical venous flow should be very low velocity, should not be pulsatile. And this is a very nice example of normal umbilical venous flow. Well, what makes us suspicious for cardiac disease when we're performing a fetal echocardiogram? Well, first of all, if there's cardiac enlargement, either overall cardiac enlargement or asymmetry in the size of the chambers or vessels, those make us suspicious for underlying congenital heart disease. The cardiac axis, that when the the fetus is in levocardia, what's the base to apex axis relative to the thorax. If you have an abnormality, if it's rotated to a more leftward or rightward axis, that may be more indicative of underlying congenital heart disease. Obviously, if you have an abnormal heart rate or rhythm, that makes us suspicious for an arrhythmia. And again, if hydrops fetalis is present, and that is, again, fluid that's collected in at least two of the fetal body chambers, including around the heart, in the lungs, in the abdomen, or in the skin, hydrops has a high correlation of up to 25% of these patients, fetal patients, will have congenital heart disease. Let's talk a little bit about fetal physiology, and then we'll move towards some other areas. So fetal physiology, the heart begins to develop during the 3rd week of the pregnancy, and the heart itself begins to beat around the 4th week of the pregnancy. About weeks 3 to 8 are the critical times when the heart is forming after conception. And as the heart sort of matures throughout gestation, there are a variety of things that we need to be cognizant of that may impact the fetal cardiovascular system. Number one is the fetal heart rate, and in particular, those patients with fetal arrhythmias may cause challenges to the fetal circulation because of a tachycardia or bradycardia. Contractility definitely matures throughout the pregnancy, and loading conditions are not well tolerated by the fetus because of the immaturity of the fetal myocardium. So they really have a limited cardiac reserve. It functions at the top of their Frank-Starling curve, mainly due to their functionally and structurally immature myocardium. You may or may not be able to improve fetal cardiac output with increases in fetal heart rate. They are very sensitive to changes in afterload. And again, with preload, minimal changes in contractility are evident in the fetal heart. When you look at the fetal myocardium itself, it has an increased amount of non-contractile proteins compared to the postnatal myocardium, meaning that it has an increased resting tension with decreases in active tension. Systolic function is typically normal, but compliance is typically decreased. And again, that EA ratio less than 1 that we can see with flow across the tricuspid and mitral valves, indicative of decreased compliance. But compliance improves throughout gestation, as does contractility, because with maturation, the number of sarcomeres and myofilament content increases, the ability of the sarcomere to stretch increases, improving contractility, and the heart begins with the improvements in compliance, the improvements in contractility, that you can have marginal increases in flow with increases in fetal heart rate due to a more receptive frequency relationship with heart rate. In the fetal circulation, we really have a parallel circulation. In the newborn, and certainly in children and adults, we have a series circulation. But in the fetus, we have parallel circulations. You have a high resistance, low flow pulmonary circulation, and you have a low resistance, high flow placental circulation. So that intra and extracardiac fetal shunts are present, and these can impact how the fetus reacts to underlying congenital heart disease. Right and left cardiac output are not identical in the fetus. The right ventricle actually has an output of about 55 to 60%, while the left ventricle has an output of about 40 to 45%. So again, a parallel circulation in the fetus versus a series circulation postnatally. The blood within the fetus has low oxygen content, preferentially shunted to the descending aorta and to the placenta through the ductus arteriosus. It travels to the placenta through those umbilical arteries. Blood with higher oxygen content coming from the placenta, flowing back to the heart, flows back through the umbilical veins. And then there are shunts which preferentially shunt blood flow with higher oxygen content to the left side of the heart for oxygen delivery. So we have, these are the three specialized shunts that we have in fetal life. We have the ductus arteriosus, which is a connection between the pulmonary artery and the descending aorta here. We have the patent foramen ovale, which allows flow returning from the placenta to be shunted across the fossa ovalis to the left side of the heart. And we have the ductus venosus, which allows that high oxygen blood to be shunted away from the liver and into the distal IVC, where it is shunted across the fossa ovalis into the left heart. The ductus venosus connects the umbilical vein to the IVC, and about 50% of oxygenated placental blood flow will bypass the liver and go to the fossa ovalis. So that's this blue flow here, which is bypassing the liver, heading to the inferior vena cava. It is a venous flow, and this is a very characteristic venous flow of the ductus venosus. Rarely in fetuses you can have narrowing or complete occlusion of the ductus venosus, leading to poor outcome in those fetuses. The fossa ovalis preferentially directs flow from the ductus venosus to the left atrium, and then the ductus arteriosus connects the main pulmonary artery to the descending aorta. And again, now you're delivering that low oxygen content blood to the placenta. So when we look at fetal blood flow to the lungs, early in gestation, about 7% of fetal blood flow goes to the right, from the right ventricle to the lungs. Later in gestation towards delivery, about 10% goes to the fetal lungs due to the high pulmonary vascular resistance that's found in the fetal pulmonary circuit. The transitional circulation after birth encompasses closure of both the ductus venosus and the patent ductus arteriosus. That occurs due to oxygen causing the release of vasoconstrictors, as well as a decrease in prostaglandin, leading to closure of both the ductus venosus and arteriosus, usually within the first few hours to first few days of life. The fossa ovalis functionally closes with an increase in pulmonary blood flow due to increased return to the left atrium, increasing left atrial pressure, and forcing that valve of the fossa ovalis against the atrial septum. But as we all know, and at least a third of us, that PFO may continue to be patent or propatent into adulthood. Pulmonary vascular resistance in the newborn falls approximately 50% in the first 24 to 48 hours of life, with a complete fall of pulmonary vascular resistance at about 8 weeks after delivery. This is facilitated by lung expansion, increased oxygen content, and a variety of mediators, nitric oxide, and other endogenous mediators, as well as the later fall in pulmonary vascular resistance by thinning of the arterial muscle that's present in the pulmonary arteries and arterioles. So again, after birth, we move from a parallel circuit to a series circuit where cardiac output increases, RV afterload decreases, LV weight or mass increases due to both hypertrophy of the myocardium as well as increase in number of myocytes that still occurs after delivery, and right ventricular mass decreases due to the fall in distal pulmonary vascular pressures. The placenta has been replaced as the respiratory unit postnatally by the lungs. The liquid environment that the fetus lives in is now a gaseous environment. So lots of changes happen that move the fetus to a neonate and from a parallel circuit to a series circuit. Now let's change our talk a little bit now and talk about fetal rhythm and fetal rhythm issues. So The normal fetal electrophysiology or ventricular automaticity begins in the third week of the pregnancy. The sinus node originates from the sinus venosus between about the 7th to 10th weeks of gestation, while the AV node and His bundle unite around the 8th week of gestation. There's conduction to the ventricles by the 12th week, and by the 16th week of gestation, sinus rhythm has been established in the fetus. Fetal heart rates throughout gestation vary depending on the time in gestation that you are. At around 6 weeks gestation, the heart rates are about 100 beats per minute. That increases to the 140s to 150s at 9 weeks. Throughout the remainder of the pregnancy and by term, the heart rates are usually in the 130s and maybe low 140s. Sinus rhythm, and in particular variability in fetal heart rate, is present in the second and third trimesters of the pregnancy. So let's talk a bit about fetal arrhythmias, because one of the hallmarks of fetal echocardiography is the ability to try to diagnose fetal arrhythmias and to facilitate therapy. So we want to be able to characterize the fetal arrhythmias utilizing either M mode or Doppler echocardiography, and that helps us facilitate treatment of the arrhythmias either by antiarrhythmics or additional therapies. The overall incidence of fetal arrhythmias is actually pretty low. So only about 1 to 2% of fetuses will have a documented fetal arrhythmia. And by far, the biggest category of those will be premature atrial contractions in about 80 to 90% of fetuses. Reentrant supraventricular tachycardia occurs in about 5%, and Epstein anomaly is a well-known abnormality that has associated SVT due to the presence of WPW. So certainly fetuses with Epstein anomaly may indeed have SVT, but we'll talk about these tachyarrhythmias. By far, most fetuses with SVT have a structurally normal heart. Bradyarrhythmias or complete heart block occur in about 2 to 3% of pregnancies. Typically, these may be due to maternal collagen vascular disease. Etiologies also include AV block, sick sinus node, and uterine contraction can cause a transient decrease in fetal heart rate with associated block. Bradyarrhythmias with congenital heart disease do occur, and they typically occur in the setting of complex AV septal defects, heterotaxy syndrome with left atrial isomerism, or fetuses with congenitally corrected transposition of the great arteries. Well, we diagnose fetal echo with a variety of different echo modalities. Unfortunately, we can't get a traditional ECG from our fetuses, so we use M mode and pulse wave Doppler to assess for the fetal cardiac rhythm. We also can look at the umbilical artery and umbilical venous flow profiles. And in addition, we want to look at the overall health of the cardiovascular system in the presence of these arrhythmias. So we look at cardiac anatomy, associated anomalies, and the presence or absence of hydrops fetalis. So normal fetal AV conduction, we can assess with M mode echocardiography as we move through a ventricle and through an atrium. So we can look at the conduction from the atrium to the ventricle by M mode. Here's a nice example of, here's atrial contraction here, here's ventricular contraction here, and we see an atrial to ventricular, atrioventricular, atrioventricular, nice one-to-one relationship of A's to V's. So one-to-one in this tracing. Well, how about this one? As we go again, we're going through an atria and a ventricle. Here are the ventricular beats. Here are the atrial beats. We can see an atrial to ventricular contraction, atrial to ventricular, normal atrial to ventricular. A beat comes early from the atrium and is conducted to the ventricle. So we see a shortened VV interval here. We see a compensatory pause as the electrical system resets, and we're back to our normal A to V relationship. These early beats can also be blocked. So this is an example of blocked premature atrial contractions. Again, here's an atrial beat to a ventricular beat, atrial to ventricular. We have a very early premature atrial contraction, and we have no ventricular activity here. So this PAC was blocked. Again, we have that compensatory pause, and we're back to a normally conducted atrial to ventricular beat here and here, and another premature atrial contraction that happens, again, very early and is non-conducted. So when we look at fetal SVT, the mechanism most typically is SVT in 60 to 70% of those with tachyarrhythmias. Atrial flutter will compose about up to a third of the tachyarrhythmias. And you can have a combination of both SVT and flutter in these fetuses in about 5 to 8% of those fetuses. The fetus doesn't tolerate SVT for a prolonged period of time because it limits diastolic filling already in the setting of a decrease in diastolic compliance with the inherent fetal myocardium. SVT causes an additional challenge that is not well tolerated to the cardiovascular system. Hydrops can occur in as little as 24 to 48 hours. The typical rate of SVT is about 220 to 320, but if you look at it and on an average, it's about 240 to 260. When we look at fetal SVT, reentrant SVTs are much more common than AV nodal reentrant tachycardia. There is a one-to-one relationship of AV conduction. The fetal heart rates are usually in that 240 to 260 range. There's usually not an association with congenital heart disease. There can be, like we talked about with Epstein anomaly, but usually not. Hydrops occurs in 40 to 50% of these fetuses. And again, a lot of these are identified after delivery of having a WPW pattern on their neonatal ECG, particularly in the setting of Epstein anomaly. Here's a nice example of a very fast fetal heart rate. Again, going through an atria and a ventricle, and we can see a nice one-to-one relationship of these beats at 248 beats per minute. So fetal SVT at 248 beats per minute. Atrial flutter is probably one of the most challenging rhythm abnormalities in the fetus. You can have atrial rates in the 360 to even, I've seen close to 600 beats per minute. AV block occurs, and by far the most common AV block is 2 to 1. That AV block can be variable though, so you can see anywhere from a 2 to 1 block to as high as a 5 or 6 to 1 block, and that can occur in the same fetus with atrial flutter. There may or may not be associated congenital heart disease. About 20 to 30% will have abnormalities of cardiac structure in the setting of atrial flutter. Hydrops much more prevalent and occurs much earlier in the setting of flutter compared to other tachyarrhythmias, and thus there's a high fetal mortality in patients with atrial flutter. Here's a really nice example of atrial flutter. You can see how fast the atrial beats are going here. For each 2 atrial beats, we see a ventricular beat. So the atrial rate measures 360, and the ventricular rate was 180 for a 2 to 1 block in this fetus. So when we think about treatment of these arrhythmias, we need to think a couple of ways. One, do we actually need to treat the arrhythmia? If they're premature atrial contractions, if it's SVT that's very self-limited and doesn't last for very long, those may or may not, those usually do not need to be treated. The treatment decision is based upon what stage of in gestation are you? Are you earlier or are you later in gestation? If you're later in gestation, delivery may be the best option. If you're earlier in gestation, you're likely going to want to use a drug given to mom that's going to cross through the placenta into the fetus as a pharmacologic management. There are hemodynamic consequences of the arrhythmia that we need to be cognizant of and that need to help guide how quickly we move from one treatment strategy to the next. Again, gestational age is important. And you need to remember you have 2 patients at this stage. You have mom who's a patient and you have the fetus who's a patient. And when we begin to talk about the antiarrhythmics, Some of these antiarrhythmics are proarrhythmic, so certainly we need to monitor mom's health as we treat the fetus with an underlying fetal arrhythmia. And these patients need very careful follow-up until the time of delivery, and then after delivery as we diagnose the cause of the fetal arrhythmia and the need for ongoing medical management or intervention with those newborns and young children. So treatment of fetal arrhythmias depends on, is the fetus hydropic or not? So if you have a non-hydropic fetus that's more stable with SVT, you have time, and you have time to use the first line drug, which is typically digoxin. Second line drugs include flecainide, sotalol, and amiodarone. When you have a hydropic fetus who's already not doing well, secondary to the SVT, digoxin is less effective, and management strategies, while institution specific, really are centered on either flecainide or sotalol as a first line drug in the hydropic fetus with a tachyarrhythmia. Digoxin in those non-hydropic fetuses, you need a large maternal dose to achieve fetal transfer. What we're looking for is a maternal level over 2 to get a fetal level of about 1 to 1.2. Fetal transfer when you have hydrops falls by 50%, so that's why we move on to the other second line drugs in the hydropic fetus. You can see that the moms need very large doses of digoxin. They need daily dig levels, and they need daily ECGs. And in particular, we look for PR prolongation in the mom who's being started on digoxin. We do all this in the ICU setting. We move moms from labor and delivery up to the ICU settings to follow them as we start these medical managements for the fetal arrhythmias. Flecainide is a second line drug, has excellent maternal fetal transfer, 80 to 100%. There are no known teratogenic effects of flecainide in the fetus. There are proarrhythmic effects that we want to be careful about. This is the loading dose and daily doses that we use. And with the maternal ECG with flecainide, we look for, in particular, for QRS prolongation in the maternal ECG. Sotalol is another second line drug that's particularly effective in fetuses with atrial flutter. So in all of our fetuses with atrial flutter, we'll use sotalol. The majority of our other fetuses, we begin with flecainide. There's excellent maternal fetal transfer of sotalol in the fetus. The maintenance dose is about 160 to 320 milligrams per day. But again, this is going to vary depending on the volume of distribution. So we do follow the ECG closely, looking for QTC prolongation. We look for impact on the fetal rhythm, and we continue to increase our dose until we see any untoward proarrhythmic effects and looking for conversion of the atrial flutter to a normal sinus rhythm. We don't use amiodarone too often in this setting. There's poor maternal fetal transfer, only 10 to 30%. Obviously, there are very well-known maternal potential effects, which and can also have significant effects of amiodarone on the developing fetus. These are the dosages that we use. If we're going to use amiodarone, certainly in our practice, it's going to be for those fetuses that have not responded to sotalol, flecainide, dig, and we're going to do an intramuscular injection into the fetus of a drug. We'll typically use amiodarone as one of those potential drugs to do that. Well, the other end of the scale, fetal complete heart block, can occur in congenital heart disease. About 50% of complete heart blocks occur in the setting of congenital heart disease, like we talked about. Left atrial isomerism or heterotaxy, complex AV septal defects, and congenitally corrected transposition are by far the most common heart diagnoses in these fetal patients. Those that have normal cardiac anatomy, think about maternal collagen vascular disease. And we often see hydrops in those that are severely bradycardic, have associated structural congenital heart disease, or may have one of those rare associated inflammatory myocarditis, typically a viral myocarditis of the fetal myocardium. Here's a nice example of complete heart block utilizing M-mode echocardiography. We can see that the ventricular contractions, the atrial contractions really have no relationship to each other and are marching along at their own rate. Treatment of fetal heart block. Again, delivery needs to be an option if we're later in gestation so that we can pace the infant. A lot of the sympathokinetic drugs, terbutaline, isoproterenol, ridodrine, not tolerated well by moms and really don't impact the fetus all that much. There have been some studies showing some potential reversal of or ongoing complete heart block in the fetus with steroids. These have not been overly consistent in the literature. And then some have tried to treat the maternal disease with plasmapheresis, prednisone or IVIG, but this has not been overly effective either in the long term. So let's finish up by looking at some fetal cases. I just wanted to show some fetal congenital heart lesions and how they look from a fetal perspective. And these are going to be very quick vignettes. So here we can see the referral diagnosis was an abnormal 4-chamber view. Remember, the diagnostic accuracy of fetal echo is highest in the 4-chamber view. So a lot of these can be recognized by our maternal fetal medicine or OB colleagues and referred for a fetal echocardiogram. This is a nice example where you have a large atrial septal defect, a large ventricular septal defect, and what looks like a common AV valve. And we can see in the short axis here, a common AV valve in this fetus. So we have, this is a nice example of a complete AV canal in the fetus, where you have a large primum ASD, a large inlet VSD, and a common AV valve. Again, remember we talked about looking at the outflow tracts and how you can miss congenital heart disease if you don't look at the outflow tracts. So if you looked at this 4-chamber view, and that's all you looked at, you'd say this fetus has a normal heart. But if you look at the outflow tracts, remember we talked about the perpendicular relationship of the aorta and pulmonary artery. Here we see a parallel relationship of those outflow tracts. So not a normal relationship of the outflow tracts, and that's when you have detransposition of the great arteries, where you have the pulmonary artery coming off the left ventricle and the aorta coming off the right ventricle. So you have atrioventricular concordance, you have ventricular great arterial discordance. So that's detransposition of the great arteries. Well, the referral diagnosis in this fetus was right heart enlargement. And if you look at the 4-chamber view, we can see the right heart is significantly larger than the left heart. And when we look at the aorta, we can see a significantly narrowed portion of the descending aorta here. So this is a big red flag for obstruction of the aortic arch or coarctation of the aorta. And remember, we talked about the fetus having a serial circulation having a parallel circulation as opposed to a serial circulation. So the fetus is able to bypass this area of obstruction. So it may be harder to see fetal coarctation because in the fetal heart, that ductal arch can bypass that area of obstruction and can mask a fetal coarctation. But when you start to see right heart dilatation because of altered flow and altered hemodynamics in the fetus, that makes you think about the fetal aortic arch. And here's again is a nice view of that narrow transverse arch as well as isthmus of the aorta here in coarctation. The Doppler profile, again, because we can shift blood flow in the fetal heart, you're not going to see the typical sawtooth pattern that you would see in a neonate or a child or an adult with coarctation of the aorta, because the flow characteristics are different in the fetal arches compared to after the time of birth. So again, yeah, this is coarctation of the aorta. Here's a nice example. Here's the true arch. Here's the coarctation segment. Here's that big ductal arch that allows blood flow to bypass this area of obstruction and go down the descending aorta out to the placenta. So again, this may be masked quite effectively in the fetus, so need to look closely for that. So here's a nice example. It just was referred as a fetal cardiac abnormality. We can see the four-chamber view here, but we can also see the aorta, or see a great vessel, which is sitting over the top of the ventricular septum. So there's a ventricular septal defect here. There's an overriding aorta. We can see over here the same. Here's the mitral valve, peristernal long axis. We can see that aorta overriding the ventricular septum in this patient. So again, ventricular septal defect overriding aorta. And now we can look at the short axis in this fetus. Here's the aorta in the middle, the right ventricle. Here's the right ventricular outflow tract. We see a VSD here. We see narrowing of the outflow tract here. And as we look at color Doppler, we can see aliasing of flow in the right ventricular outflow tract due to narrowing in tetralogy of Fallot. So again, we have tetralogy of Fallot, where we have right ventricular hypertrophy, we have a large ventricular septal defect with aortic override, and we have narrowing of the right ventricular outflow tract, causing significant obstruction, and that leads to a bidirectional shunt at ventricular level in patients with tetralogy. We talked a bit about interventional procedures becoming more common in fetuses, and that's certainly true in hypoplastic left heart syndrome. This is a fetus who has hypoplastic left heart syndrome. Here's the right atrium, right ventricle. Here's the left atrium, and the atrial septum here appears to be intact and bicolor. We really don't see any color flow going across this atrial septum. So this is a very high risk for poor outcome during gestation in patients that have, fetal patients that have an intact atrial septum. So this patient actually went an interventional procedure, had a septostomy done to open up the atrial septum, and then had a stent placed during fetal life here. Here's the stent in the atrial septum to allow the egress of blood from that obstructed left atrium over to the right atrium into the right heart. And then I just titled this one, What? This is something that you won't see every day and you may never see in your career, but as we look here, here's the fetus. Here's the head of the fetus. Here's the abdominal wall of the fetus. Here's the chest. What's this thing beating out in the area black? So out in the amniotic fluid, we have the heart. The heart's out beating in the amniotic fluid. Here we can see it even better. Here's the chest wall back here. Here's the heart outside of the chest in the amniotic fluid beating out there. If you look closely enough, you'll see an overriding aorta here over a ventricular septal defect. So this fetus not only had what's called ectopia cordis, and that's where there's an abnormality in the chest wall and very commonly in the abdominal wall as well, that allows the heart to be outside of the chest. And there's a high association of congenital heart disease in patients with ectopia cordis. This one had, as I said, tetralogy of Fallot. This is my only embryology slide that I'll use for the entire talk, and I use it at the very end. But this occurs very early in gestation with abnormal closure of the chest wall and, like I said, abdominal wall as well. And that allows both the heart and some abdominal structures to be outside of the fetal chest and abdomen in this condition. So in summary, I think we've quickly gone through a lot of the advantages and the importance of fetal echo, both in the diagnosis of these patients, in the counseling of families, in the coordination of the medical care and surgical care teams, and in those fetuses that require prenatal therapy. Fetal echo plays a very integral role in whatever that prenatal therapy is. And I know that a lot of you, most of you, are adult echocardiographers, but I think this just gives you a little flavor of what your adults were back in fetal life and how these lesions looked, and why fetal echo is an important component in our imaging repertoire. And I appreciate your attention to this and look forward to interacting with you in a question and answer session at a later time. Thank you very much.